Hey, everybody. Welcome to another episode of the Fix Yo Shit Show, where we talk about the shit show that's out there, and then we teach you how to fix it yourself so you can avoid that whole other side. And if you've already been down that other side, no problem. You are where you are. We all learn lessons. Some are harder than others, but that's what we're here on earth to do, to learn and to grow. So today I'm very excited to have you here.
Thank you.
I have Dr. Emily here. She's the founder of Naboso. Her and this is our first time actually meeting in person. I actually people send me all kinds of stuff, right? I get stuff sent to me. I actually don't even take free stuff anymore because that means I at least have to follow up with them with an email about it. And I think who did I meet? It was in Dubai. And I got sent over your products.
Ah.
And I put them down on the ground and I stood on it. It was instantly, I go, that's it. She's on to something with this. This is needed. So what Dr. Emily, she's a podiatrist by background. We're going to get into that. Can I tell you something? I always say podiatrists are the most useless profession.
Thanks. But I'm not just a podiatrist.
Uh-huh. I know. I do say that, and actually, because I have a lot of friends that are actually podiatrists too. I kind of mess with them with that. Because I see it's just orthotics. Bunion surgeons are breaking bones and moving things over.
Supportive shoes.
It is just like the ultimate support everything and don't run and don't jog. I rarely hear somebody coming out of that thing actually better. No, I do those times, right? But as a whole, I'm like, I just try to keep people out of there.
I get it.
I know you get it.
I get it.
Because you're out of there.
Yes. That's why I've challenged the profession.
Right.
And I'm a black sheep within the podiatry profession.
What do they think about you?
Well, here, let me tell you this. So when I was in the earlier side of my career, kind of breaking some of the dogma, is that I was actually scheduled to go back to my school and speak on behalf of the American Women's Podiatry.
They didn't let you do it.
I'm on my way there, and they pulled me last minute and wouldn't let me go in and present.
Guess who relates with that? Mm-hmm. Mm-hmm. Does it make you feel kind of alone, though? In a way. Do you ever feel like, who do you have? Because you got the people.
Well, I have other people. I don't need my profession to feel whole.
Right.
But I do have my friends that I went to school with who have supported me the entire way. When I would get hate mail, I literally got hate mail from podiatrists saying, you are single-handedly ruining this profession. You're an embarrassment to this profession.
What was the criticism?
Well, this was in my catwalk days.
Hold on, let's do a little time error on this one. Okay. Let's go. You graduated when, and then let's go through kind of just like a really like a timeline.
Yes. So 2008 is when I graduated school.
Yep.
To start residency.
Got it.
And residency is 3 years to learn to do surgery. You have to learn to do surgery. But coincidentally, at the same time, I was in the fitness industry and I created this workout. It was a barefoot workout for women who wear heels. So this is also in the Sex and the City days.
This is
in New York City.
Are you a Sex and the City fan?
Oh my God, yes.
My wife, that's her comfort zone.
Yes.
She watches them all.
Carrie Bradshaw, hello.
She was disappointed by the new season, though.
Oh yeah, no, yeah, just like that, no, yeah. No. But anyway, so I created this workout for women who wear heels, and the media, New York City media, just ate up. And they were like, podiatrist endorses heels. And it became very polarizing to the media.
Wait, endorses heels?
Yeah.
They interpreted it that way?
Yes.
Typical news spinoff.
Exactly.
Typical
news. So the profession just freaked out that they thought I was endorsing high heels, and I wasn't. I was saying, if women are going to wear heels, I'm going to give them the resources and teach them how to reset their feet, how to strengthen their feet, how to build the posture and the core and the pelvic floor.
Yeah, but when did this happen? You did not learn this in podiatry school.
No, I mean, a lot of that not in podiatry school, in the fitness industry.
You were in the fitness industry?
Yes, for 10 years before this.
Before podiatry?
As I was going through podiatry school.
What type of fitness?
Like
you were a trainer? You were in fitness? Like a Pilates?
Both. So my background is actually gymnastics. So I was a competitive gymnast for 13 years. And then I got into fitness. Then I was doing personal training, teaching classes, all of that. And I created my own workout. That's how this
Oh,
evolved.
I see.
Yes. So I graduate, create the workout, media picks up on it. I absolutely hate residency because it's so isolated. I fell into this crazy depression and I was just like, what the fuck am I doing with my life? So I quit residency and was
Really?
and I was like, I'm just going to do this media thing. So I just pushed into
Is
media.
that what got you on Oprah?
Yes.
Ah.
Yes. So that was that little era, my era. So when I was doing all of that is when I started getting the hate mail.
When you dropped out of your residency, you still were you weren't licensed yet, because that's part of your license. You have to complete that to get your license.
Correct.
Interesting.
But what also happened is I quit residency, started doing this media, traveling. I was doing Oprah and all these other media shows. And then I went back to school and I got my master's in human movement. And I focused on barefoot science because at the same time of all of this was the Born to Run and the barefoot running boom.
Wait, there was a okay. You went to school again for human movement, a master's in that.
Yes. In 2010, 11, 12.
You just love to accumulate debt, don't you? Do your
You don't want to
investors
know how
about this?
much debt I
Do they know about this?
Shh. My secret.
No, we can do the math real quick.
Yeah. There's a lot. Yeah. Keep pushing that number up. So I went back to school and it was in parallel with the barefoot running boom, minimal shoe boom.
Yeah.
So I was then like, hey, my workout, which yes, I market it to women who wear heels, is really a barefoot workout. That's what I'm talking about at the end of the day. So I started changing and evolving more into barefoot science. And that's really where people know me today.
I see. So when you you never got your, did you get a degree?
No. I did. Oops, sorry. Let me go back because it's very important. Because I am a licensed podiatrist.
Oh, okay.
Yes, I am a licensed podiatrist. So I get my master's in human movement, and then I say, I paid $250,000.
Might as well finish, go for the 10-yard line in the end zone.
Exactly. So I said, I need to get licensed.
Yeah.
So I went back to residency, did the 3 years, trained as a surgeon, got licensed, played the game. So I am licensed, and I did surgery for 5 years.
Oh, wow. You actually stuck with
did.
you went, really?
I did.
Isn't that kind of, there's a dichotomy of that, because you're trying to keep it alive. And I know a lot of the people you're seeing, you go, if you just would do this and this, you wouldn't need this.
I know. Okay, so here's the thing, Mike. When you get the check, the first check that I got for doing surgery out of network, I still have a photo of it. Imagine going to school for 13 years and you're like, oh my God, I made $50,000 in a 3-hour surgery? Like, cha-ching, baby. Like, cut it up. Right? Obviously, that's not
They're like,
how
hey, you get paid this as long as you drink the Kool-Aid.
Yes. As
long as you keep
so
drinking it.
it is very easy to fall into these Western medicine beliefs of pushing surgery and pushing medications, et cetera, because, I mean, part of that's just human nature to be incentivized by money.
Hey, I remember when I was billing insurance as a chiro, I remember there was this code where if you billed it, we were getting $900 for a back brace.
Mm-hmm.
And I would go, oh, Blue Cross ripped me off before. I'm just getting that much. By the way, I think I'm past my statute of limitations. Hey, guys, make sure to look into that before we post that part. But it's also easy in there to justify that, because you see insurance as a game. Oh, I play this, I bill this, I get this.
Is.
Oh, it is a game.
It is a game, and people don't realize that if you know which modifier codes to use or use this code versus that code, you get it. It's dirty. Which is why I dropped out of insurance.
Same here.
Yeah.
I was on 2017. How about you?
2017.
Really?
Yep.
I left too. I go, this is so, I'm doing things and getting these checks. I'm getting them in. But really for me, I felt like the whole system was so limiting to helping somebody progress and improve.
Yeah.
It was so much about getting it right now and relief and keeping them in the system and making sure they still have pain that I just go, man, this system is just so rigged, and it's just not, it's so limiting to people's possibility.
It is. And then, I mean, you're also, what you can do, if you do play the insurance game, you are also just limited by what you can bill in one appointment. I remember when Obamacare first came out, and I was still in private practice under insurance, and I was like, I'm sorry, I can't treat more than one condition in one visit. Do you know how ridiculous that is? Especially in
The
podiatry.
foot, and then you go. What else? What would you treat? How would you treat? In podiatry, everything is just foot.
I know.
Your education is the foot.
Yes, I just don't like that, right? And then I've had surgeons who would say, no, I actually can't do both of those procedures at once because they wanted to do primary billing on both to get paid more. And I'm just,
And then you gotta lie to the patient. Oh, you know what? Let's address this later.
Yeah. So I've cleansed myself of insurance.
Gee, it is a total cleanse, right?
Yes. And now I'm actually a huge educator on patient advocacy. So patients have to have a voice and realize they have a voice, and you can challenge things. And I remember that I did that when I had my daughter, that there were certain things, and I was like, no, that's not right. No, you need to do this. And I really spoke up for myself.
So, okay, with medical, let's kind of dive into something else here. Now, you have your podiatry license, which is still, you're upholding an oath with them to be a certain thing. So there is still liability on your end.
Oh, absolutely. But everything that I do...
Do you need it?
I do. So I'm licensed in Arizona and New York. So I carry 2 state licenses. And I do it because I still see patients in person and do injections, regenerative injections.
Really?
Yes.
Regenerative
Yes.
injections?
I'm a big believer in regenerative medicine and the role that it plays in the functional longevity space. It's a great option before surgery, right? I think you should do literally everything you can, exhaust every treatment option.
And that's not 3 visits to your PT, and it's not, I tried. There's no trying, there's doing.
Yeah. So you are doing these different ones all the way on the bottom.
Stem cells,
is then-
PRP,
yes.
is this what you're speaking of?
Yeah. So I do Wharton's jelly. So those are umbilical cord matrix based. That's one that I do. I used to do amniotic based, and then the FDA came in and kind of messed that one up a little bit. I used to do PRP. I don't anymore because I don't have a centrifuge, so I can't spin it down. So that's why I do Wharton's jelly.
What are your primary, what have you found most successful with these?
2 conditions in the feet. Partial tears of the plantar fascia, which I actually see a lot and is missed. Second is a partial tear of your plantar plate.
Your plantar plate?
And your plantar plate is a ligament under the toe, most common in the second.
Okay.
And when it tears or it lengthens, degenerates, etc., the toe starts to float.
Float which way? Up?
Up, and you can actually sublux it.
Oh, so is it a stability ligament?
Yes, so it's actually part of your plantar fascia.
Oh, it is.
Yes, your plantar fascia, as it goes towards your toe, it splits, and then it inserts onto the base of the toes as that ligament, which is called the plantar plate, which is actually your plantar fascia. Yes.
So with the first one, we get the plantar plate, and then you said the plantar fascia.
Partial tears.
Partial tears.
Of your plantar fascia.
We say partial tears.
Partial tear.
I mean, how often do you see more than a partial tear?
Not as often as a partial tear.
What do people feel with a partial tear that's different from just, plantar fasciitis?
Yes. So a partial tear of a plantar fascia, I would always keep that as a differential. If a patient is not responding to any other treatment, they've had it 6 months or over, so it's like the chronic fasciosis, right? And that there's some element of degeneration. Anytime there's degeneration, you're at risk of partial tear.
Degeneration of what?
The plantar fascia.
So anytime with degeneration, thickening.
Yes, so it's thickening. And then
Can you see that on ultrasound?
You can. Yeah. Yes, you can do it on ultrasound, MRI ultrasound.
Okay, got it.
So one of those. Yep.
Okay.
And then typically it'll present in a very specific way. Most of my patients in my practice they've exhausted all these other providers. They've had tried everything. They're like at their last kind of wit's end as far as what are my options. And then they're coming to me. And then typically that's where I'm thinking, this is so obvious. A chronic plantar fasciosis that you've had for multiple years, there's a high chance you have a partial tear. And literally no provider thought that.
What were they
it blows my
thinking?
mind. I don't know.
Did they just think plantar fasciitis?
Yeah, I don't know. I don't know
What are these
why.
people doing? They're going through the ringer. They're getting orthotics. They're getting
Physical therapy.
What are they doing? These PTs for this generally.
Maybe some Graston. maybe shockwave. I do think that shockwave is a little overused
Yeah.
and not done appropriately based off of regenerative medicine protocols. So I would do it a little bit different if I was doing
Do you
it.
see benefit in shockwave?
If you
I'm
do it
hearing
the
more
right
of
way.
it. I've been hearing my whole, but this
Yeah.
seems to be a little more popular nowadays.
Okay, so here's the logic behind methods like shockwave, or there's like topaz or different radio frequency. Whatever you're trying to do, you are trying to piss off the tissue.
Okay.
You have a chronic injury, let's say to the plantar fascia. Could be any tendon or connective tissue, but it's chronic. It's in a state of stasis. It's like a pool of murky water. It's just sitting there and it's like, bleh.
Can you confirm that on ultrasound?
Well, that's when it's thicker. So when it's thicker, that's degenerated, and then microscopically, physiologically, pathologically, that there is going to be, it's called neovascularization. The way that I explain it to patients is think of it like a haystack. And this haystack is this disorganized pile of baby blood vessels, different types of collagen type 1, type 3, almost like scar tissue. And it's just chaotic. I need to make it organized. So it's like a rubber band again.
The chaotic tissue is going to be fibrotic tissue, and
Yes.
and surrounded by this kind of murky, stagnant, white blood cells, some
Yeah,
kind
so-
of fluid.
Yeah, poor vascularization, you could
Okay.
say.
Because that area statistically is low, like poorly vascularized to begin with.
Yes.
Right?
And yes, but some people will actually use the word necrotic. And this is very, very different. I know you're into kind of like busting myths and stuff
Right.
like
Necrotic
that.
is like dying tissue.
Yes. So when I hear people say, plantar fasciosis, you shouldn't be doing this or this because it's necrotic. It's necrotic tissue. I'm like, if it was necrotic, that's like gangrene.
Right.
Like that's like black. It's dead.
Are people really going around saying this? Necrotic?
Yes.
It
yes.
scares people.
Yes.
I'm
does.
dying.
It does. So
I'm like, well, we all are, but yeah.
what
never
it
mind.
is, what it is it is hypoxic.
Okay.
That's a little bit different. Hypoxic is decreased circulation, microcirculation.
It's
That's why.
oxygen-starved tissue.
Yes, but that's also why I use the term just chaotic.
Chaotic. The tissue's chaotic.
Just like a
'Cause you do have to
haystack.
relate to the person.
Yeah.
You have to say in a way they go, oh, that makes sense.
Yeah, and I don't want to scare them,
Right.
right? Right. So,
Right.
here's the other part of the thing with a partial tear, which I think is important. I find it interesting. Who knows? Is that your plantar fascia is actually 2 layers. You have a deep layer and a superficial
Oh,
layer.
I didn't know this.
Yes. And when you get a partial tear, I don't know if this will make sense, but you can tear just the deep fibers and not the superficial fibers. Or you could tear just the superficial and not the deep. So then this becomes this very haphazard, almost like a rope that has frayed. And some of the things are connected, some of the things are not connected.
I mean, how thick is each layer? Average.
I mean, micro.
Oh,
Micromillimeters.
Okay, got it.
Right? So you're not talking like very thick, but it's enough to create this disorganization. Right? So when you do the surgery to release plantar fascia, which I've done, an endoscopic plantar fasciotomy, what you're doing is you're cutting the fascia and then you have to pull the toes back as hard as you can to get the pieces of the fascia as far away from each other as possible.
What, you're,
so they don't.
you're further stretching the already chronically stretched tissue?
Because you're releasing it. You cut it, and then you need to move the pieces farther away. Because what happens is if you tear, this is when someone tears, even a full rupture, is that the fibers stay close to each other, and then they start to connect again.
Again, and tighten up even further, maybe.
Yeah, and now you have scar tissue, so you really need to go in there and.
So on this plantar fasciitis surgery, I'm a little confused by this one. Can
Mm-hmm.
you maybe clarify that again? So if there's what they're going to do is they're going to cut the fascia, but what part of the fascia are they cutting?
So.
The plantar fascia itself?
Yes.
So what is it actually called, this procedure?
It's an EPF,
Yeah.
endoscopic plantar fasciotomy.
Endoscopic plantar fasciotomy.
Yep, and think of this as your heel, and you are cutting with a little hook, like a blade hook, that you go in and you are cutting 2/3 of your Achilles tendon, or your plantar fascia, as it originates on your heel bones. You're just cutting and releasing. Pull the fibers, move them far away from each other. So you have 1/3 of your plantar fascia still intact.
1/3 of the thickness of it?
No, of the
width. The width of it. You're cutting
Yes.
through 2/3 of it.
Yes.
And then you're opening it.
Yes. Yes. And what I will say for patients that I've done this on is that as soon as you do that surgery, they respond like that. Their pain goes away. So I've done it before. I remember doing it on a TSA employee, a woman who worked for the city of New York. She drove a bus and she was just like, I can't not work. And I was like, I get that, right? Like, I don't believe in surgery as much as possible. I want to delay it. But I have to relate to you, right? So I get it. You need to work. You need to feed your children. I will do the surgery that's going to get you relief like this.
So the way that from a biomechanical standpoint that I usually see plantar fasciitis is, right, if you have a natural arch in your foot, the plantar fascia has let's just call it a proper tone to it, right? And as our foot flattens, now that fascia is lengthened.
Yes.
And now that extra lengthening and that constant pull is creating inflammation. So when you cut it, it would biomechanically cause the foot to further flatten, but them not to feel the stretch because it is now released even further.
Well, yes. Can I word that a little bit different?
Please.
Okay. Okay. So what you are doing when you do this dropping of your arch to stretch the fascia, that's called arch compression. That is how you potentiate your plantar fascia. Potentiate means you are putting energy into the fascia so you can release it when you take a step.
I missed that part. One more time.
Okay. So when you compress your arch.
Compress your arch. Okay. When we say
Drop.
we flatten our foot, drop our arch.
But this is dynamically, right? So every
Sure.
time I take a step, my foot is doing this. Okay. So I'm dynamically compressing my arch, pulling the fascia.
Right. It's pull. The fascia is pulling as we
Like
dynamic.
a rubber band, like
Yes.
I'm pulling a rubber band, which is potentiating it.
Oh, okay. Potentiating. It's giving it some action. It's giving it
Some energy.
Energy.
And then when you lift your foot up to take a step, the rubber band comes in and you release energy. That is really the purpose of our fascia, all of your fascia, not just your plantar fascia, is that energy return. So when you do a fasciotomy, you release a fascia, you obviously don't have arch compression anymore.
Right.
Yeah.
And it relieves it.
Yes, but you now have less energy potential in your foot.
So let's take another example. If instead of cutting 2/3 of it, if you just cut the entire the origin
entire
of it
fascia.
and just remove the whole plantar, they likely wouldn't have plantar fasciitis pain either.
Well, true. But
It's essentially part of that.
Yes. So what research studies have shown is if you do release the plantar fascia, 2/3 of it, you're cutting it, or if someone ruptures their plantar fascia, which is possible, you then start to destabilize the forefoot. There's something in your foot called a tie bar mechanism.
Tie bar.
Tie bar. Yes. So your plantar fascia runs from your heel into your toes, right? And as it comes into your toes, it creates a ligament that connects every metatarsal to its neighbor. Okay, so you're from the heel to the toes.
Splays outwards.
And then it goes like this. So it creates a T in the foot, okay, if that makes sense. So the tie bar mechanism, I did not learn that in school. I learned that through studying historical foot biomechanic experts.
Cool.
Yeah, like that's where I've learned some of the most powerful stuff of how I look at the foot.
Whoa.
Was actually from historical podiatrists.
Who are these people?
And then they just like don't teach them anymore.
Yeah, why would they? Because it would be, why would we solve the issue? What?
So remember like Morton's toe?
Yeah.
Morton,
Oh.
there's a Dr. Morton. There's
That's a good
actually
place
two.
to start.
There's two Dr. Mortons.
Okay, that would make sense. Not the Morton Salt, the Dr. Morton's.
Yes. And then there's like a root theory of biomechanics. These are different theories of mechanics where East Coast podiatrists are actually trained different than West Coast podiatrists. So a Cali doc is trained different than a New York City doctor. We just have a different theory of biomechanics at which we're taught.
So, back to this from your experience with this plantar fasciotomy. Is that what that
Yep.
is?
The release, yes.
The release. What's your observation about how that alters mechanics? I know you talked about it a little bit, but can you maybe go a little more with how that alters mechanics?
Yes. So from an altering the mechanics, you could say maybe a little bit delayed stability in the foot. Delayed stabilization. Now, delayed stabilization of the foot could cause stress fractures, Achilles tendon issues, neuromas also.
Because as that arch flattens, that they would usually experience a rebound effect because that rebound isn't there. Now they have to rely more on actually their ability to contract certain muscles to do that, or to shift their weight over to do that.
Yeah, they would probably become a little bit more reliant on the posterior tibialis.
Oh, interesting.
Yes.
So posterior tibialis, I'll tell you what, there's a lot of muscles that this one has always given me issues because we start on the outside, and that is going to it's a foot everter.
Inverter.
Damn it.
Sorry. Failed.
It's an inverter.
It's
the
an
posterior
inverter.
tibialis is an inverter?
It's on the inside of your foot.
I need a fact check. Not from Google either. Not from a fact
Are
checker.
you doubting?
No, go ahead.
Are you doubting the podiatrist?
Well, I mean.
This podiatrist? Come on.
So it's an invert. Okay, so basically what that muscle does, the posterior tibialis, is it turns the foot in. The bottom of the foot turns inward.
While plantar flexing it. So what your posterior tibialis does, which is along the inside of your ankle,
It relies on that muscle to activate to correct from the actual surgery that.
Yep.
God.
Yep. So your posterior tibialis, the way that the listeners can kind of think about it is, imagine like a high heel position, right? Or if you do a calf raise.
Sure.
That position of your foot is called a rigid lever. That is a very, very special position of our foot, and that is controlled by your posterior tibialis. No other animal can do a rigid lever like a human.
Interesting.
So the reason that we can run, jump, do all the athletic movements, dance, literally all the cool shit that we do from a movement perspective is because we can create a lever in our foot.
So that we can, as we plantar flex, we have the ability then to turn the bottom of our foot inward and outward. A lot easier inward than outward. Man,
Yeah. You want to turn inward because that locks your rear foot. And then as soon as your rear foot is locked, your tibia externally rotates, essentially locks into position, and then your hips can activate, and that's how you activate your glutes. So from your foot to your glute, very much connected.
So back to the hip glute. These people that come to see you as a last resort, plantar fasciitis, because this is a super common one. I get this more than anything, right? In the foot, plantar fasciitis is number one.
Yep.
What presentation do you see them? What presentation in terms of the posture of their foot, the position of their foot, their ankle, their ability? I don't know if you take them through functional movements. Do you have them lunge? Do you have them do a squat? What is that common presentation that you see biomechanically?
With plantar fasciitis?
Yes, the people that come to you with it.
So it actually depends on the person. So it could be an overly flat foot, overpronation. So they're collapsing in, limited ankle mobility, but it could also be a higher arch foot. So I see it also in what's called a cavus foot. So it's just a little bit higher arch, more rigid. So both of them.
How would that make sense with the high? Because the high arch, technically, they would put more weight on the lateral, on the outside aspect of their foot, and thus taking the tension off of the plantar fascia.
Well, here's the thing with a high arch is that a high arch foot, which again is called a cavus foot, oftentimes is at end stretch of their plantar fascia, just sitting there.
You mean end stretch or end in the most shortened position? The most shortened position.
The most. They are taut.
Taut. Yeah. They're tight and short.
Which means they have no ability to arch compress.
Because they're already in their most contracted position.
Yes.
And therefore, when they go into it,
you have no choice but to micro tear it.
Very similar to other areas. I mean, even like, let's take somebody, for example, that has lordosis. Or back. These people are in so much hyperextension. Their erectors they're constantly in the shortest, most contracted position and making it difficult. And so that's so injured. I guess I've always associated the plantar fascia as not a structure that contracts and expands.
Yeah.
I've always seen it more of a rigid, rope-like. What can you tell me about the elasticity? If you've been in cadaver lab where you've taken one of these plantar fascias and you try to work the stretch on it, what would you say the...
Yeah, I mean, I would say it probably is, I mean, it's not as elastic as the Achilles tendon, but it's very similar to the Achilles tendon. And the Achilles tendon is where we house most of our energy return during dynamic movement. And is myofascially connected to your plantar fascia.
Sure.
So they're really the same piece of tissue.
Wait, it's a
right?
continuum. It goes right
It's just a
underneath and
continuum.
connects.
Yeah. Now, what I will tell patients is, or when I do workshops and I'm talking about foot type and plantar fascia, is that if you feel the bottom of your foot, when your foot is relaxed, you should not feel your plantar fascia. You shouldn't feel it taut. Then if you bend your toes back, it like pops out, right? Because bending the toes back activates the windlass mechanisms. You're making it taut, or you're tightening the plantar fascia. But people who have high arches are essentially the equivalent of, in that windlass mechanism, just standing there. So what happens when they start moving? Well, they're going to micro tear it.
This is a great test. So you have people feel the bottom of their arch. And I mean, the plantar fascia, right? Because this is a rope-like. It'll ding, 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 opposed to being able to push into muscle like you would push into a bicep.
Yeah, just literally feel the bottom of your foot. Oh, okay, where's the plantar fascia? I don't know. I don't feel it. It's there somewhere. I don't know. Bend your toes back. There I feel it. Right? That's in a normal foot what you should be feeling. In a high arch foot who has a taut plantar fascia, literally just sitting there, I can see the fascia sticking out.
Got it.
Yeah.
Got it. And I guess the same way if you would do this to your neck, you see that platysma muscle right there. I've been working on mine for years. How's it looking?
It looks fabulous.
Okay. I'm still going, actually. I got work to do. More protein, more reps.
Almost there.
Almost. A never-ending pursuit. Okay, so to this presentation, you have the high arch foot, which is really fascinating. I often see people, what they have is they think they have a high arch, but they're standing on the outside of their foot, because if they put their weight over their toe, everything collapses inward. It's like this pseudo high arch foot.
Yeah. So, I mean, I always teach people how to set their base. It's probably a good thing. We should be on our tripod. A proper base or foundation or plantigrade foot is what it's called. You are on a tripod.
Tripod.
First met head, fifth met head, heel. Toes are long, straight, and flat. So you want to have a long toes. And then you slightly externally rotate your hip, which will lift your arch.
It's a beautiful quick fix for a lift, isn't it?
Oh, yeah, totally.
Right up it goes.
Right. Boop, like this. And then you want to just connect to your toes, because your toes are how we maintain balance. So I teach people to just kind of say hello to their toes.
Tripod should be equally dispersed.
Yes.
On a stand. What about in gait? Just a walk.
It depends on the phase of gait.
Let's just talk about our strike phase.
So how we strike the ground?
Yeah. Let's talk about strike phase to whatever the hell that one is.
So initial contact. Initial contact, walking is supposed to be on the outside aspect of your heel.
Okay.
This is important because a lot of people will come to me and say, Doc, something is wrong with me. I'm wearing out the outside of my shoes too fast. I say, guess what? That's normal. That's what you're supposed to do, right? So you strike the outside of your foot or the shoe first.
So not the center of the heel.
No. It's the outside.
Outside aspect of the heel.
Outside. So you are inverted or supinated, right? When you strike the ground, you are then going to roll to the center of your heel this way.
Okay, so we strike and then we go to center.
Yeah. While simultaneously lowering down to the lateral edge of the foot. And then you go 5, 4, 3, 2, 1.
Oh, piano it.
Yep.
Bring.
Like that.
Oh.
Yes.
By the way, we got to work on something. I'm going to tell you. I spend so much of my time trying to simplify complex. Invert, evert, supinate. It's fucked up. It is like, we got to have an easier way. I say, like, your ankles roll in. Your ankles roll out.
Sure, you can call it that.
Do you have a simpler way of doing this? Because invert, evert, because it's referring to the bottom of the foot.
Yes.
I wish it would refer to the ankle. If we could invert the ankle, I know
I don't know. I didn't make up the terms. But
we got to make them easier.
So what I tell people, because a patient or any listener, they don't really get what invert evert means, right? So
No, and
instead,
sometimes I mix it up too.
yeah, so we're all human. It's okay. But when you roll to the outside of your foot, or you're in like that high heel position, supinated, whatever that is, really what that means is you locked your foot. You locked it, right? You can lock your knees. When you stand straight, you locked your knees. Or you can evert, roll inward, flatten your foot. You've just unlocked your foot.
This is very good.
So
When our
those
locked foot is our strongest position of the foot.
Yes. So when your foot is locked, it is ready for power. When we unlock, you unlock to load. So think of like locked and loaded. I don't know if that helps people, but you are locked, you're loaded, you're ready to release power.
You're basically moving it into that spring, and you're whatever it is, your
Everything's
momentum's
potentiated. Yep. And then you roll into your lever and boom, you release it. Yeah. So when I see a patient, I'll explain that. I'll say, here you're locked, here you're unlocked. You're a little unlocked, but it's okay. You know, like versus saying like, oh my God, you are pronating. And they're just kind of like, I don't know what that means, but it sounds bad, right?
Because unlock. Okay, so
Just
then
unlocked.
you would have people, some with a flat foot. How would you explain to them what the position their foot needs to be more in?
Well, that's a stable base.
Let's say they're completely flat.
Yep. So I have them
They're
roll
unlocked
their foot.
completely.
All I have them do is roll their foot. I don't even use words. I just say, hey, stand with your feet shoulder width apart. Roll all the way to the outside of your feet. Roll all the way inside. Roll outside, inside. Oh, do you feel your legs rotating as you do that? Do you feel your hips rotating? Okay. Well, we want to be balanced in the center, which means you have to go a little bit this way, which will lift the arch so they feel, oh, I can rotate my hips out, right? So I'm just teaching them the movement so that they can connect to it. Then, which is really important, is that I will have them do it facing a mirror because a lot of people will be like,
When they see themselves
I'm
the
neutral,
first time,
right? And then they're like, ooh.
they
I'm not
gaslight
neutral.
themselves.
I know.
People gaslight the hell out of themselves.
I'm totally neutral.
Right.
Yeah, no. Yeah. So I want people to really connect. So then I show them and I say, no, that is neutral. That's where you're supposed to be. And then they're like, oh, okay, that feels weird. And then they just adjust to it, right? Yeah.
So okay, here's what we should do. Maybe it's a big leap, but I would like to leap into Naboso now. I would love to do this because this presentation, so some of these people that you see, these last resort, and probably Regeneration, this is great to know, by the way. I didn't know that you still practice that. I'm totally on board with that as well. I definitely believe that's the future as well.
100%.
Because if I can get somebody like what I teach, I get people in the right position. I teach them how to strengthen this.
Yep.
Yeah, but that tissue still has to heal.
Exactly.
Yeah, maybe over 5 years
Yes.
it would, but it's still like, how can we accelerate that healing?
Yes.
And I often find what I explain to people is their tissue isn't healing because their body's always trying to heal, but what they're doing is they're these poor mechanical patterns are outpacing their body's ability to heal. And so, yes, I get them neutral, and that helps most people. They're like, well, this is great. I'm good, and then they get better. But the ability to inject nutritionally, and this is not an aspect that I'm an expert on by any means, is how to accelerate that tissue recovery.
Can I share a little bit on how I do it?
Yeah.
Okay. So there is what's called local. Local is kind of zoned in, right? Like we keep talking about plantar fascia, so we'll just stay with it. But your plantar fascia, you have a micro tear or a partial tear. That's local, right? I'm zoned in.
One little area torn.
Local. Versus global is your whole system. Okay, so this is obviously how your hips are stabilizing, in coordination with your feet, your pelvic floor, all that stuff, right? Your movement pattern. That's global. What I find, which is kind of what you were saying, but I just want to share a little bit on how I think of it, is if you fix someone globally, I'm going to fix the movement pattern, right? Where you're saying your right hip is not activating fast enough. That's why you got right-sided plantar fasciosis, right? Okay, so let's fix your hip. But if you don't fix the local tissue injury and the tear, just fixing the global movement pattern will never heal that connective tissue.
Does it?
No, it won't. It won't. That's why that's the patient that I treat.
That's what I wonder now, though. But maybe this patient, you may not see the ones that
Well,
globally fix it.
Well, no. So, because you cannot, if you have a tear in your plantar fascia, you cannot repair a tear without surgery or something regenerative. You just can't, right? So you will get patients who are told to, you tore that plantar fascia, you're going to be in a boot for 3 months
Sure.
and it'll heal. Bullshit, it's not going to heal. It cannot heal without surgery or regenerative injections.
I do want to clear something out with my audience, though, because I talk about this. I've pretty much looked at different studies. You name any area of the body. I just looked at one yesterday in the knee. In a study, 250 44-year-old average adults with no knee pain, 97% of them had clinically relevant findings.
Some sort of
tear to the meniscus,
or
ACL, MCL.
Yeah,
and so
yeah.
there is this aspect of, yes, the tear maybe cannot heal, but they're going to go into their ortho. There's the tear. Let's do it.
Yeah.
Because the ortho assumes that the tear is causing the pain.
Yes.
So I do want to clear that up with them. We can have tears that don't heal and have no pain.
100%. So what I would say on that, which that is actually a really, really good point, because foot tissue is a little bit different than any other part of the body. It's under different load.
It's under a lot of load.
And stress, unlike any other part of the body. And that's why there's like the chronic presentation of these things, and it's so difficult. So I 100% agree with you, like on the knee and the meniscus and, maybe some MCL, LCL, whatever it is, right? Some bulls, right? Things, shoulders,
Sure.
right? I have every injury in my body as well, right? But there's something about the forces that are acting on the foot and the tissue and the connective tissue within the foot, the fascia and the ligaments, etc.
Can you find that do you see that this regenerative medicine does in fact
So
heal?
I will do MRIs before and then several months after. And you will see an improvement, okay? But to follow with what you said,
Improvement in the tear.
In the tear, yeah. So
amazing.
Yes. So, but this is an important differentiation. So you could say, okay, you don't need to do these injections. You don't need to do the surgery if, let's say, you have a tear in your plantar fascia, but I could immobilize you and you could still have the tear and you have no symptoms. However, here's the thing. What is the level of activity that you want to be able to do?
Right. And do you want to rest for say? And by the way, that's I almost always hear people. They always seem they've been in a boot and it just comes right back. It weakens everything else, and then they're depressed over it. At what cost?
Right.
Especially people that want to stay.
Yeah.
You and me. I want to stay moving.
Super active. Yes. So that's where I say, if you want to continue to, hike Kilimanjaro, whatever you're doing, right? You're going to push your connective tissue past its physiological limit.
Right.
Which means I need to help you restore some of the regenerative connective tissue properties of that tissue. It's a subtle distinction, which is good that we're talking about it, because I could see
subtle distinction
where someone could hear one sentence that I say or you say, and then it can be pulled out of context because there's all this other stuff that is important for people to understand what I'm trying to say on it.
I have a tear. I have a bucket handle tear in my right meniscus from 15 years ago.
Yeah.
I've never had surgery. I've never had a follow-up MRI. My knee is good. It starts to hurt if I stop doing the things that I need to do. I do my daily foot grip. I get my rotations in the mirror. If I'm doing those, I'm good. If I don't, it hurts.
Yeah.
And this is important, especially because now I do think there's positive aspects of this pain science movement coming. But big pharma's already behind this. 40% of behind them, they're just go, how can we get people on antidepressants and anxiety?
Yep.
But the pain science, I believe, is at least educating the doctors that it's more than just a physical thing.
Right.
So I do think there is some positive with that. But this is a main one that I hear is like, oh, I got a tear in my meniscus. I have to get surgery for it.
Yeah.
I have a tear in my plantar. I have to get surgery. But personally, I believe that the sweet spot is improving their functional movement in combination with. I do believe. I have just had difficult time finding those people, those surgeons that we can collaborate with at an equal level in agreement about that.
Yeah. No, we are in agreement.
I love this. This is fantastic.
we are totally in agreement, right?
I'm sending you all my foot people.
One thing that I would also say with the regenerative, and then I could keep talking about it, but we don't have to keep
I
talking
love
about
this.
it.
Like I
is-
said, I'm like, are you limited time? Because I know this is going to go.
So when I do injections, is I actually have my own protocol. And I will share my
Of
protocol
course
with
you do. Because you're
So-
not, you're an outside the box thinker.
So I have my own protocol. I always piggyback the injections. So I do always on every injury or whatever it is, I always do 2 injections. So injection, 2 weeks later, I piggyback it to just kind of re-kickstart it. I am immobilizing a patient.
You're giving it a booster shot.
a little booster. Yes.
Yeah, anyways, go ahead.
And then I'm immobilizing the patient for 4 weeks.
Oh.
Yes.
Okay. Because
This
you
is
don't
important.
want strain on it. Now's the time for that tissue to
No.
heal.
And this is where the shockwave that you mentioned earlier.
Oh.
So shockwave, the way that I will have patients do it is I want them to do shockwave for a week or 2, right? And then boom, I'm going to do the injection.
Just a
So
quick,
they're
just a
leading
powerful
it
electrical
up to it.
stimulation to just trigger
Yeah.
that area, growth factors to naturally migrate to it.
Yes, but really what it's doing is it's pissing off the tissue, right? And the regenerative injections are growth factors. So if I can start to create a injury response, which means circulation, right? All the increased vasodilation, and then I push the growth factors into it, right?
So do you stimulate it first?
Yes.
Oh, so basically you're gonna anger that tissue 1st, and then you're going to
Yes.
inject
Yes.
second.
Yes.
Because there's already a
Yep.
comb.
Exactly. And then I stack photobiomodulation with it.
What is this?
Red light.
Oh, we have one of those.
I just had to use the fancy word.
See, here's the thing. I learned fancy. My wife, everyone's always like, I told you, I'm like, I don't remember. See, I don't remember. But I carry
keep it
with
real.
me this like level of understanding that doesn't really have words to it. Red light, photomodulation.
Red light,
yeah,
yes.
yeah.
So red light, and then also systemic enzymes.
Oh,
So I
oral?
love, So I love systemic enzymes that I don't know if you know much about
No.
them. Serrapeptidase is one, bromelain, quercetin, just a couple other ones. In the foot, there's a company called Step Strong.
These over-the-counter things?
Yeah.
Okay.
Yeah, so it's not prescription. But systemic enzymes you take on an empty stomach, it goes into your bloodstream, and then it naturally modulates the body's inflammatory cycles. It's also
modulates.
this is like
Come on now.
the legal advisement
Talk
of
to
how
me like I
to
don't know what I'm talking about. Talk to me like you talk to your patient.
it naturally modulates the body's inflammatory cycle.
Oh,
Yes.
I get it
like-
now. Go ahead.
It's playing with the inflammatory cycle. Okay.
Hang with it.
Anyway,
How so though?
so it
We mean it modulates. It is doing what?
is decreasing pro-inflammatory cytokines.
It's decreasing the inflammation there.
Yes. And
I've got you, don't worry.
and it is naturally antifibrolytic.
Anti.
Fibrolytic.
Oh, so it's gonna prevent scar tissue.
It breaks down scar tissue.
It breaks it down.
Yes.
We do
So-
want it though.
No, this is in. Remember the chaotic haystack?
Yeah, but hold on.
It's a chaos.
With this tissue, these stem cells,
Yes.
what is the tissue that is regenerating? Is it scar tissue or is it
No, it's stimulating fibroblasts
yes?
to release collagen.
Okay.
Yes. And you want
collagen is
collagen
considered-
type 1, not collagen type 3. Collagen type 1 is healthy, rubber band, elastic.
Oh.
Collagen type 3 is like scar tissue.
So this peptide, the enzyme,
Yep.
prevents it. Number 3.
Yes. Yes.
It doesn't promote number 1, but just prevents number 3.
Well, it's starting to break down the 3.
The 3.
Yeah.
So what is it? Let's just say I tear something right now. Let's just say I tear my annulus in my back. Okay, a disc. Okay, my body's laying fibroblasts down.
Okay.
It's trying to lay down type 1 or type 3. Or
Type
both.
3. Type 3.
Really?
Yeah. Most of
Three.
these injuries are repaired by type 3.
Does it take this injection to stimulate type 1? Is it not a natural?
Yes. Yes. So you're stimulating the fibroblast to support a more controlled collagen formation.
Which is type 1.
Yes. That's the healthier one. that you want.
But this tissue though, and it gets like these stem cells, it's not growing. Let's just say a stem cell would attach. I don't even know, but it's not regenerating the same original from the factory plantar fascia tissue.
Well, no, because it's stimulating. So all these injections, PRP, Wharton's jelly, exosomes, are really growth factors. So if I inject them into my knee, not a knee that has worn down cartilage,
Sure.
right? So you're trying to repair the cartilage.
Okay.
It will stimulate a chondrocyte, which is the cell that creates the collagen or the
meniscus tissue,
the cartilage. Oh my goodness,
the actual cartilage,
the cartilage
from the factory
yes.
cartilage.
Well, yes.
Oh, your original cartilage, like
yes.
Okay.
Yeah.
These are my terms.
I've just never
This is
heard
what my
that
audience.
term
This is what my
before.
audience likes me, by the way.
Okay.
They go,
I'm
that makes
trying
sense.
to navigate
From
this.
the factory tissue.
Okay, from the factory tissue.
Because we got the stuff that you're born with that grows, and then you got the aftermarket shit, which is scar tissue. But you're teaching me there's two types of that. There's type 1 and type 3. The aftermarket.
I've just never heard it described this way.
The aftermarket, I want type 1.
know.
I don't want type 3.
Okay, sure. Yes. You want type 1.
Yeah.
That's collagen. The chondrocyte, which stimulates cartilage, is healthy cartilage. You don't have cartilage 1 and 2, like the same as collagen.
Oh, I have
it's a
scar
little bit
tissue.
different.
Oh, I have cartilage.
Yeah, cartilage. Yeah, for the knee.
Why
right?
Why not the plantar fascia though?
No, it does.
Cartilage.
Oh my God, I feel like I'm being punked.
Cartilage. Because it's different.
Yes.
You're saying that we got the knee, you could stimulate.
No, you
it grows
do.
Cartilage.
You do. So if you were to inject bone, it's stimulated an osteoblast. Right? Like
Yes.
every tissue has its little builder.
Right.
That's what I want the listeners to take away.
Yeah, its own builder, its own type of tissue.
Yeah.
Yeah.
Does that help?
Yeah, but the plantar fascia,
That's a fibroblast.
which produces,
Collagen.
what is the factory tissue made of? The plantar fascia.
Collagen 1.
Oh, I get it. Just so you guys all know, we were talking about the same thing the whole time. It's the plantar fascia's collagen 1.
Yes.
So it grows back the original OG factory tissue.
The factory tissue.
Not.
Yeah.
Collagen 1 is the factory tissue. Collagen 3 is scar tissue.
Yes.
They may have picked up on that before me. I don't know. I hope not. I hope not.
Oh my goodness.
So
yes. So my regenerative.
amazing.
My regenerative stack.
Yeah, your stack.
My stack
Huh?
is maybe you do a little shock wave,
Sure.
then you do the injection.
Yeah.
We're doing red light
Yeah.
the entire time, and you are taking systemic enzymes.
Got it.
And we're doing that whole little stack
Yep.
for 3 months. I'm following the patient for 3 months because it takes 3 months for new collagen to remodel to healthy connective tissue.
And because that arch is designed to have a rebound effect on it,
You want it to be like a healthy rubber band.
we want to minimize the rebound while that type 1
Yes.
is growing back.
Yes. So the way I explain it to a patient is I say, imagine a fracture, right? If I fractured my arm, I would put it in a cast, right? And then in the cast, I don't want the fracture pieces to move because technically what's happening is the osteoblast, which is a cell, is building a little bridge, right? He's trying to build a bridge to the other side of the fracture to then make it stronger.
Right. You got to complete the
So
bridge.
you cannot move the pieces.
Right.
Think the exact same thing with your plantar fascia. I'm not trying to shake up the fascia while we're trying to bring integrity to it.
So, I can't tell you, because when I'm out in public, I see somebody or people see me, they got like some boot on their foot. What is that? Doctor said I sprained it and wear a boot. I want to be clear. This is a lot different than somebody just telling you wear a boot, because they're under this impression, rest, ice, elevation, compression, this old school model. This is not what we're talking about here. We're talking about booting the foot so that this type 1 collagen the tear can become bridged and restore back to factory conditions.
Yes. So if you see one of my patients in a boot, don't knock it.
I will knock it. How many people are doing what you're doing?
I don't know. I mean, I learned it in when I was practicing in New York.
They teach
But
this?
yeah. But in my group, I was part of a large group in New York City. There were probably 12 of us docs. I was the only one doing it. And my colleagues were like, how are you selling this several $1,000 injection
That's
so
right, 'cause
easily to
insurance
your
just
patient?
fills up the office is easy.
Yeah,
Your
but
insurance doesn't cover this.
no. Insurance does not cover
Right.
it. But they were like, how are you selling these injections to your patients when they're a fee-based service? And I was like, because I believe in them.
Because you believe in
I believe in the injections.
the injections.
Yeah.
Right,
So
'cause
then
you
a
believe in
patient,
it.
right? And I would say,
Right.
okay, here's your options. Let's say you're coming to me. I'm going to give you all of your options from the most conservative to surgery. I will give you all of them because my job is to educate you. And then ultimately, it's your decision of what you want to do. It's your body.
That's great. 'Cause I'm biased. I'm like, you can go see this bullshit doctor who's going to do this and this. Those are your options. Was that biased?
We all word it our own way, it's totally fine.
I do want to be clear, though. I really do. I know that there's like 10% at the top of every profession that's excellent. There's 10%, I believe, every profession that is like holds the profession up. Excellence. I just see, because you think of my volume. My audience is 3 million. We have had 250,000 members. Plus, I've had, 20,000 in person.
Mm-hmm.
I mean, it is just the classic orthotic, the boo, the rest, the it is just such, and then you go, how was it we took it off? The same. But then again, here's the thing. I'm only seeing the people that it didn't work for. I guess I'm not giving credit for the ones that they did that thing and somehow miraculously it did work.
Yes. So, I mean, some are doing it right.
This is amazing. Holy crap. Wait, let's get into Naboso now.
Okay.
But I could do this we need to do this again. This is great. I'm learning so much.
Yes.
I think my audience is going to love this.
I hope so.
There was also that I learned about you from the product, Naboso. And guys, when you see this thing, and as soon as I reached out to them, I go, the biggest problem they're going to have is marketing this thing because it's this texture. This is the magic. These little knobs. These little pyramids of Giza. The tops are on these ones. But I stood on it and I felt it. And the reason why I loved it is because, like you said, people gaslight themselves. They go, no, I'm standing right. Really, are you? So I love the mat. That's my favorite, is the yoga mat.
Okay.
I know it's one of your least sellers. And I think the only reason it's a least seller is because the texture is difficult to market. But I have my clients stand on that in front of a mirror.
Yep.
And it provides instant feedback of weight distribution of that tripod.
Mm-hmm.
Instantaneous feedback on that one. And I think your products like the board, the Kinesis board, I think those are good. I think it is in the footbeds, and I think it is in the mats. I think that's the strength of your product. But the other ones look cool, and so people buy them. That's what I believe. Now, they work.
Yeah.
They work. Don't get me
work.
wrong.
They do work.
They work. But I think the value is standing on that mat every day, doing your squats, doing your slow lunges, feeling that foot position, having your foot. But I think that's the heart of it. Mm-hmm. And the other ones are nice to work on ankle mobility. Don't get me wrong. The Kinesis ball to work deep tissue, and they're fantastic.
Yeah.
So, but there was this knob thing that like this idea of this. What do you call the pyramid?
What's a pyramid?
There's pyramid. Each one's
It's
a pyramid.
a texture. Some people call it a node.
A node.
A node.
Oh, that's nice.
I mean, it's a texture. It's stimulating 2-point discrimination. It's a pyramid.
What is 2-point? What is this? 2-point discrimination?
It's like Braille.
I don't discriminate, especially with 2. Okay, I'm trying to. Oh, it's like. What is it?
It's like Braille.
It is like Braille.
It is like
It's
Braille.
like Braille for your feet.
I have used that before.
That's good. That's good.
Yeah.
It's like little. I don't say pointy because we're like. Ooh, it's like a little.
So it's a point.
It is a point.
But it's not. And it's acute. So acute means not sharp. I don't want to use that word.
You want to be it. Well, you want to take because you don't want to scare people. It is a pyramid-shaped structure, tiny, rubbery, that has some give to it, and it allows. It is a sweet spot because it's not uncomfortable, and it's not comfortable. It's the most. It's like walking on a bed of nails in a way. Let me hold on. It's not uncomfortable. It's like walking on a bed of nails.
It's not.
On a bed of nails, for example, if you want to really hurt yourself, just stand on the outside of your feet on the bed of nails. If you want it to be the most comfortable, you would distribute that equally amongst all of them. And these are like little more comfortable versions of those. And so
You're not selling it, Mike. You're not.
look, these guys toughen it up. This stuff, you honestly, every one of you needs to get one of these yoga mats. Okay, they're like $150, whatever it is. You get this, you lay it down on the ground, and I want you to stand on, do your lunge squats. You will absolutely, it'll help you understand your foot position like nothing else I've ever seen in my life. But the point is, how did you develop this? When did it happen? Was there an aha moment?
Yeah. So there was. So
why?
Naboso launched our mat, which you love, was our first product.
Yeah.
That was going to be a barefoot training surface, a surface that would stimulate when people took their shoes off. That beta test launched 2017. 17, 18, 19, that was kind of where we were testing the market a little bit.
Same texture as today?
Actually, no, it's changed a little bit.
Okay.
But I was approached in 2015 by an engineer. I was in the industry consulting for companies about feet. And he was working for one of the companies I was consulting with. They were trying to come up with a foot product. And I was like, that's not really going to work. And I said, I have some ideas for foot products. And then it just never worked. He left that company. He came to me and he was like, essentially, I'm a free agent. I'm a free engineer. He's like, you said you had some ideas. Let's do it. And I was like, oh, the world is talking to me.
Okay.
I'm supposed to do something. Okay. So what I was thinking of is that between 2012 and 2015, when I started doing this, so for like 4 years, something like that, I was traveling the world teaching about feet, barefoot science, barefoot training, just all of that for one of my companies. And I was getting people out of their shoes, but then no one was talking about the surface they were standing on. And I was like, well, if you're going to get your athletes out of your shoes or your clients, well, you then have to have intent and purpose behind what you stand on, the actual surface. So I started researching surfaces. This is where coming up with a surface. So I started reading textured insole research. There are dozens of textured insole research studies.
Like walking on glass.
Not really that, but they showed all of these great benefits. And I was like, well, there's all these research studies and people just keep researching it and no one is doing anything with it. Like, what is the point of research if you don't do anything with it?
I was at Spalding Running Center at Harvard.
Okay.
And we were in the basement. It's like a dungeon. It's like right out of that. It was like right out of the movie Independence Day. Remember they go in the basement, everyone's
yes.
Staying. And they were like, they have this stack of research on like basically why high-heeled running shoes, high cushion, are hurting people. And they were like, we came out with a new one. I'm like, I've never seen any of these other ones. We got to get these out there.
Yes, you have to do something
with it.
You got to
do something with it.
Yes. So essentially I use that research to then develop my product.
Oh.
And because it was based off of that research, it's not a mirror of the research, but it was inspired by the research. And then there was all the other R&D behind it, blah, blah, blah. I had to defend my patent. So it took 5 years for me to get a patent.
Defend it against who?
Them saying that it's
prior
based.
art.
Yes, it was all prior art. Saying that there were research study. It was this research study showed this.
But
yes.
Was anyone selling anything with it?
No.
They don't need to as long as it was.
It's research and published.
Oh.
So then we show that ours is different.
Are you patented yet, or are you still patented?
We have 5 patents.
You do?
Mm-hmm.
Okay.
And this sock just got his patent granted, a utility patent 2 days ago.
She only has 5 patents, and that's just for these top 5. You're going to be 1,000 patents after this. Stupid joke. Go ahead.
But yeah, so we finally got a patent around it. But that's how we came up with it.
Oh.
And then my background is in athletics, fitness. That's where I pushed it. And then one of my students at one of my workshops for trainers happened to have MS. And he was like, do you know what this is doing for my MS?
Oh.
And I was like, no. And he was like, I need to hook you up with all these MS centers and
musculosclerosis.
multiples.
I put muscular dystrophy, multiple
Multiple
sclerosis.
sclerosis, yes.
I am not the expert in this.
It's okay.
Okay.
We still love you.
Very good.
But yeah, so then that actually opened up Naboso.
It didn't sound right when I was saying it, honestly.
Is it-
What I
it's
said at the
fine.
beginning, it wasn't coming out right.
All good,
Okay.
all good. So then that's where we pushed Naboso into neuro rehab.
Wait, just multiple sclerosis.
Yeah, MS.
Help define that.
What, MS is?
Yeah.
So it's a chronic neurological condition that falls under movement disorders. So central nervous system, similar to Parkinson's, not the same, similar, different part of the brain, limbic system that is affected, but, decreased balance, increased fall risk, foot drop, neuropathy, very common with people with MS.
Okay, got it.
Yeah.
Okay.
So having something that builds foot awareness, like an insole, a sensory insole when they walk so they can feel their feet, is going to decrease falls in someone with MS.
So were they using it as one of your foot beds? Guys, I love the foot beds. That's my number 2 product. It goes in your shoe. It's completely flat. There's no cushion. There's no arch in it. It's super flat, like a thin piece of rubber, and it has this texture on the bottom of it. They're absolutely fantastic.
Yeah, thank you.
You're welcome.
That was our second product.
I really mean it. I mean all this stuff. Yeah.
Thank you. But yeah, so that's how we came up with it. And then fast forward now. So 2020 is what I consider really our true year, because that's where we did the colors and the branding. And really it is what the company is today. And then now, 5 years later, we have over 40 different products.
Oh, there's 40 now? Holy cow. I haven't looked at your website in like 8 months, I guess. Jeez. Must have got 15 more of them.
Yeah. So we essentially are trying to just demonstrate that the benefit or the utility of the texture can be on all these different products.
Like what?
Different
Can you kind of,
songs.
not all 40, but can you just run through like the applications of this?
Well, yes. So we have our mats.
Yep.
We have our insoles.
Yep.
We have 4 different kinds of insoles. Well, 5 because we have children's. We have 4 different mats, right? So that's already quite a few products. We have the socks with grips, socks without, toe socks, studio socks. We have a balance board that you mentioned, kinesis board. We have our foot wedges that manipulate the foot.
I love it. You know what I'd like though too? I'd like those wedges to be a little bit longer too. I'd like a longer set.
Like wider?
Yeah.
Okay, noted.
So I could squat on them a little bit more.
Okay.
I squat on yours. I bounce it off. I got one from Foot Collected and I have yours. I squat with them every day. I mix them up. I like it because my heel's up on it. But if but it's as steep of an angle, if it could be longer, I could have my whole foot on it. I could only put my heel on it right now.
Okay.
But it's great for heel. I still love
Yeah.
it. But a longer version would love that.
Okay. Noted. Thank you for that. I will bring that to the R&D department.
What else?
And then we have weighted sticks. So those are sensory sticks. We have wobbles that go on the kinesis board. We have a neuro
I
stick.
guess I don't know weighted sticks. Am I rolling on the stick?
No. They're weighted. They're for your hands.
Oh, they're for hands.
Yeah.
They're hand stimulation sticks.
Well, yes. So we consider them a neuro tool. So when you hold something that is weighted, lightweight, so these are 2 pounds each, you actually wake up the brain and you can improve someone's balance just by holding something.
Okay, got it. You're
Yeah.
going up to the hands now. It makes sense. I mean, the hands, your feet. This is
We have
high
a
sensory.
hand activation kit as well, so you can actually squeeze it. There's air in them, so like grip training. You have that. We have our neural ball. Can't forget our neural ball. 2 different colors.
Yeah, the Neuroball's awesome how it pops open. I
Yep,
love it. It's really
opens. So
cool.
you have 2 domes. We have our toe spacers. We have some license agreements where people will license our material and make different products. We have some Pilates equipment that we've launched. And then we have another 4 products that we're launching this year.
Wow.
Yeah.
It's great. Because it is the texture, so it goes, where can you put?
Yeah, that's really, and then people email us all the time saying, why don't you make it on a golf club?
I was thinking of a mountain bike too.
Yeah. People have said
Ooh,
that.
A
on
grip
bikes.
training for a golf club, that
Yeah.
would be fantastic.
Yeah. So then people
Oh, the golf industry, that would be really
golf, rackets. You're thinking like paddleboard, tennis.
great. Right. How about different firmnesses of these?
So part of the efficacy or the R&D behind this is that we have to have certain durometer hardness. Harder surfaces and harder stimuli are more stimulating to the nervous system. So the durometer is very important on these, right? So the hardness of them, the materials that we use, very important because that's to hold the shape, That's actually why it took 2 years to make our first product.
It was like deforming.
Because we could not figure out like what material to use, what's the tooling process. The pyramids weren't pointy enough. Right. So it was a blend of materials. So it's a lot. There's a lot of specificity in it.
How long would they last, like the footbeds?
Well over a year.
Well over a year for those.
Yeah.
Like a pair of shoes.
Yeah.
You would wear.
Yeah, something like that.
Okay, got it.
And then there's been some other people that played with texture a little bit in it. Call them competitors if you want. And
I know none of them.
That's fine. We will not disclose names. Their texture or their stimulus was completely different, meaning not hard enough, not tall enough, the distance and just all the characteristics
They're
and
on
the
the
feature
rookie
of it.
phase.
Pretty much, yeah.
You guys were where I was 8 years ago.
Yeah, so I'm just like, meh, it's fine.
Yeah, you stay ahead of it with that.
Yeah.
Now, with this texture, like when I teach people how to do short foot exercises, I teach them inversion, eversion. I like teaching it. I mean, it obviously works. But with this, there is something that happens that's different. There is a natural response from your body that can occur without even thinking about it. Have you ever measured that with people about not even saying anything? Like having people do squats, lunges just for the sake of exercise on like maybe the floor versus on this. I'm curious if you've seen anything with natural, because people are going to gravitate. I would think people are going to gravitate away if their weight is on the outside of their foot. There's a discomfort there. And I would assume that they would naturally want to turn it in to better distribute those forces.
So we haven't done like force plate studies.
Oh, yeah, okay.
Right? That could be one way to do it. We did do a couple subjective studies. So subjective is your opinion.
I know what you need to do.
Oh, okay.
So right now I'm partnering with a company. They're called Kinotech. They do 3D biomechanical assessment.
Oh, okay.
Love these guys. And so what they do is it's a LiDAR camera. And it measures very accurately.
Okay.
Tibial rotation.
Rotation. Yep.
And I have one in my house too.
Oh.
That might be
some
really great to get some testing with them.
Okay.
So you could look at some data points on that.
Yeah.
I think that might be really beneficial.
So I haven't done. So yes to that. Hook me up or sign me up. I'm all about the data. So we have done some IRB controlled research studies. Those are all like MS, Parkinson's, neuropathy. So very specific medical conditions. Those take forever because they have to get funding. But the IRB, if you remember the IRB, it just means that it's like legit research.
I see.
Okay, there's like...
I don't know what legit research is nowadays. It's whoever pays the most money gets the research.
There is a board and a standard of safety and approval on the whole process.
That's what
right?
the FDA said too. Look, I don't doubt your research, by the way, but the research industry is definitely tarnished right now.
I get it. Yeah, the FDA totally different, right?
Yeah,
I totally get it.
Yeah,
totally get it.
Yeah.
But sure, I could understand why there's hard feelings around that word IRB.
But I have no doubt that this product would produce results like that.
Yeah. So the one that I was going to share that was subjective, though, we did a golf one, which was interesting.
Golf.
Yeah.
Okay.
So we had 40 golfers who had never used Naboso use our activation insole in their golf shoes.
Okay.
And then just do an 18-hole.
Oh.
And then we're just like, what do you think? Blah, blah, blah. And we asked a few questions.
Oh, subjective one.
Yeah, so subjective, right? But it was really interesting to get people's feedback and be them saying like, oh, I walked the greens. I always walk the greens. And by the end of the 18 holes, I'm like, whoo, like tired. Like, well, my hammies are tired, right? They were just like, whew, let's sit down. And they were like, I was ready to go. Like after the 18-hole walk in the greens, they were like, I felt amazing. Some people said that they golfed one of their best games. Like it was just kind of this.
One of their best rounds.
Sorry, I don't know. I don't golf. I don't know.
I know. Just like I don't know multiple muscular sclerosis.
I know. Our weaknesses are coming out
and
now.
also, by the way, diabetics, anybody that has type 2 diabetes or your parents have them, buy them the footbeds. Because with diabetes, you're losing, the blood becomes sugar and it gets pulled in the foot and you lose sensation. This is where you fall over and tip. Yeah. Get them a pair of these for their shoes.
Yeah. And they're safe.
Of course they're
because
safe.
But they might, in the space of neuropathy, especially diabetic, that some people may be like, oh, is this going to
puncture my skin?
Yeah, just like a braise it, lacerate it. I don't know. Somehow create an
I
opening.
get the safety thing too. I always get that.
Right. But we actually are doing a research study on diabetic neuropathy.
Oh,
So-
that market's huge. I mean,
safe.
everyone's just getting fatter and fatter.
You know. Yes.
The market's
I'm not allowed to. No, just kidding.
Yeah, well, people need to fix their shit, and not only that, but not only look at the ingredients, not only look at the calories, but look at the ingredients that are made too.
Well, yeah.
It's gonna get better. I'm confident right
There
now.
is a rise in diabetes, which means there's a rise in neuropathy.
Of course, and it's something that
But this is all type of neuropathy. It's like chemo-induced neuropathy. That's on the rise.
chemo-induced.
Yeah. 1 in 4 people have cancer.
Oh, and
It's
there's a
ridiculous.
neuropathy after, of course.
Yeah,
It's freaking brutal
yeah.
procedures.
Yeah. Idiopathic, autoimmune,
Sure.
right? So there's a lot of different types of neuropathy.
So we're saying, for the simple, neuropathy's a neuropathy.
You got a
You're
numbness in
losing-
your feet.
You got a numbness in your feet.
Use the Naboso.
Even someone might have like sciatic kind of weakness in there, I think will benefit from this too.
Yeah.
So what else have you found with people's mechanics? What do you see with them with their ability to distribute their pressure on their feet with Naboso? Is this something you personally are interested in looking at? Maybe it's not a personal interest as much.
No, so it is. I am particularly thoughtful of dynamic balance.
Oh, okay.
Right.
Sure.
So, which kind of goes towards what we were just speaking about, but
gonna
it's
be
not
more
just.
practical. More practical. Yeah,
right?
sure.
We do have a lot of athletes that will use it because they want to feel their feet faster, right? So
Sure.
from a performance perspective, that makes sense. A lot of dancers who will use it because, again, all these athletics and dance, etc., very into their foot placement, ground awareness.
You need an 8 foot by 10 foot mat. I'm telling you, I'm living and dying by this mat.
I can tell. They're very expensive to make.
Whatever. Who cares?
I know.
People buy them. They're
I know.
awesome. Well, don't
I
get-
love the mats. I love the mats.
Well, maybe I can help you sell more of the mats too.
And we have flooring too. Did you know that?
No.
Yes.
You have flooring.
Yes. Oh my God, I forgot to mention that. Yes, we have flooring.
Whoa, interesting.
So my podiatry office.
No get. I want it
is-
from my bed to the toilet in the middle of the night. There's no getting away. You wake up, I don't give a shit if you're half tired. You are walking with good distribution of your foot. That's what fix your shit is.
Yes.
If your eyes are open, you're focused on it. Hardcore.
You could put the Naboso in your entire home if you want.
I want on the walls.
I don't care. You could.
Furry walls.
Right? Yeah. Oh my God.
You remember the movie? That's one of my favorite scenes ever.
Which movie?
The furry walls. You gotta rub the furry
No.
wall. Get
No.
him to the Greek. Irene knows she's Greek. She better know. You never see Get Him to the Greek?
No.
It is okay.
Noted.
Yeah. Well, I send you the scene. Diddy's in it actually.
Oh.
Still a good scene. Not gonna lie. Okay, it's a good scene. Good scene. But I didn't do your flooring with it. That's awesome.
Yes.
Is it like big tiles?
2 foot by 2 foot tiles.
Okay.
So think of like a standard tile.
Yeah.
That you would get in a gym for a gym.
Yeah, like yay thick.
It is 10 millimeters thick.
Okay.
1
1
centimeter. Jinx.
1 centimeter is going to be about a little more than a third of an inch. Okay, for some conversion ratios.
Okay.
Yeah. Wow. Okay. What else are we going to talk about with Naboso? What I miss?
I mean, we talk about the hand.
Sure. If you want to talk about that.
Hand, cool.
I wonder if I'm missing something. Like you're more involved with the. You're more involved with you. I think you're a lot of your focus is on the actual neurological stimulation, maybe brain processing. I'm very much on the physical, connect the mind to the movement, do the movement.
Sure.
Of course, there's all this,
Yeah.
regenerative, what the word I'm looking for, my brain is kind of firing on 3 cylinders right now. But right, this is happening inside to do that, but maybe there's something you want to touch on with what's happening from like a neurological.
Well, yes. So, I mean, when I think about Naboso and neurological, other ways that we could think about it, not just in the stability pathway, which there is a stability pathway between your feet and your pelvic floor, which is fascial based. So when you feel your feet faster, you can faster stabilize your foot to core, pelvis, hip, glute activation.
That makes a lot of sense. Yeah, if you're in outward rotation, I feel a pelvic floor lift if I do. If I get a grip and I rotate outwards, it's easier for me to contract my pelvic floor.
Yeah.
I feel that.
So that's why athletically people like it.
Yeah.
I like the connection of when we feel our feet and we ground or anchor our feet, that we feel more connected emotionally.
Yeah, so okay.
So we work with a lot of people from like a stress, autonomic nervous system, kind of that side of things, stress responses, anxiety, things like that.
Okay.
There's also a cognitive protective response. Actually, the way that I love to talk about feet and cognitive protection has to do with walking speed.
What is cognitive protection?
Your brain, so that you don't lose your memory.
Oh,
So you don't want dementia,
sure.
right? You want to look good and be present, right?
Yeah. Well,
Yeah,
if you don't want
hopefully.
dementia as well, make sure don't eat pesticides. Stay away from farms. I mean, the pesticides from there. Don't eat the poison food that's in knife when you're eating. But on top of that, we also can.
Well, so from a movement perspective, to live a long, fruitful life, you have to be able to walk fast enough. So walking speed is actually a predictor of longevity.
Oh, that's good to know.
So as you slow down your walking speed, there's a correlation in morbidity and mortality.
Oh, hey, everything's slowing down. Slow it all down.
Yep, it just slows down. So one of
interesting.
that. So to me, that's very interesting
It is interesting.
because again, research is published saying like, did you know that if you slow your walking speed, you could die sooner?
Right. That's a good
So then
blog
they
topic.
and they go and they call it the sixth vital sign.
Yeah.
I read research like this and then say,
Do you like research?
I love reading.
You love
research.
reading it?
Yeah, I love reading research. Not as much anymore.
Do you
because I'm
remember
like,
things like authors and
A few. I will do a few, like especially the textured research. Hatton is one of the best texture research. She's an Australian.
Hatton?
Yep. But with this research study about walking speed and morbidity and mortality, again, people publish it and then no one does anything with it.
Right.
So instead, I would say, okay, well, if I don't want to slow my walking speed, my job for my patients or for people is to tell them what to do
To
so
walk
that you
faster.
don't slow down your walking speed,
Right.
right? Your foot,
Your foot
is
feels
obviously
better and you're more confident in your foot, and then you
Yes.
you strike in a position that's ideal. You have better mechanical leverage. You can move at a more efficient speed, comfortably longer.
Yes. And you know what is one of the most important things to walk fast? You have to be able to stand on one leg because you have to take
Back
long
to dynamic
steps.
balance.
Yes.
Right, because every time, people don't understand, every time you step, you're balancing on one leg.
Yeah.
Every single time. And then you get people to stand on one leg and they tip over. I'm like,
Mm-hmm.
you're not going to, you won't be able to make long strides. You got to do little strides because you're
Yeah.
tipping over mid-stride.
Yes. And I know you love biomechanics. So when you take a long step, in order to take a long step properly to get the walking speed, you have to be able to rotate your pelvis one way and your rib cage the opposite way.
Sure.
Right? So you are decoupling or counter rotating your spine or between your T-spine and your pelvis, right? You have to be able to do that to walk fast. A lot of the people that I see in my office where we see this decline is that they're walking with no pelvis or T-spine rotation, which means they really aren't taking long steps.
Right.
They are walking, technically it's called a staccatic step, but the way that you're walking is very short and shallow.
Right? Because your chest, right? You're walking, you're running, your chest is going to stay forward. And the further that hip goes forward, the hip has to go, but then relative to that torso actually is rotating back, even though you think it's straight ahead, and you're getting spinal rotation.
Yes. Have you read the book about the spinal engine?
Oh, I have it on my shelf.
By the author is like Tchaikovsky.
Old book, right? I have it on my shelf. I've had it about 2 years. I go through like 15 books a year. Probably more than that actually. It's on there. It's not in queue right now. You know what? The first thing I did when I bought it, by the way, I scroll. I'm like, there's no fucking pictures. That's the first thing I skip through.
What?
I go,
I know.
where's the pictures
I know.
of body mechanics?
You like the pictures.
Well, it motivates me to get into the book to get to the picture. If there's a picture I like on page 80, I'm gonna read it to get to it.
I know.
Give me intermittent rewards.
It is a dry book. Yes. Yes. But what he says, which is really fascinating, is like a hummingbird. So a hummingbird is like flapping his wings really, really fast, but it is so accurately able to go into the flower, even though its wings are moving like crazy. And essentially that is the author's analogy to say there's a lot of motion happening down
I see.
here.
I see.
From your foot is doing this. When your foot does this, your leg does this,
Sure.
right? Then it goes into your hip. Then your pelvis is doing this, and then you're going like this, and your T-spine rotates this way, right? So you have all this moving up your spine, and that's necessary to keep your head level and your vestibular system so that you can walk.
It's necessary to keep it, or your head is going to stay level, and you're only going to move your body the amount that it can move underneath your head. And if that's limited, you're not going to have much movement.
Right.
Because you're not going to have your head going side to side when you run. The eyes just they like to stay straight.
Right. And walking is actually a lot of rotation. And people don't realize that. There's
Rotation,
so
where
much
else?
rotation. Your T-spine, literally everywhere. Your T-spine is, your pelvis is, your hip is, your knee is, your tibia, your subtalar joint is doing not a rotation, but it's doing a movement.
And that's also one very
that feeds
overlooked
it.
movement is rotation.
Yes.
It is, many people that are at the gym, it's always this forward and back push movement, but rotation is one of our 7 functional movements. Meaning, if you want yourself to, I always tell people, what's the best exercise? I'm like, well, if you're doing your 7 movements, your pushes, your pulls, your squat, your lunges, your rotation, if you're doing those in alignment, you're taking your body through every possible range in preparing yourself for it. Many people skip on rotation. I see what you're saying is if they're walking too, and especially a slow walk, there's minimal rotation with that. Some. But the longer our stride, the more rotation is required in our body to do that. And we want the most mobility in our body as we can. And we don't want to slow down because we'll die.
Right. And the big part of this is that when you walk fast, you're moving your ankle, you are activating the circulatory pump. And there's really cool research that when you walk at a certain pace, you then get circulation all the way to your brain. And then that stimulates brain-derived neurogrowth factor.
No, I'm very familiar with that one. Brain-derived
Growth factor.
neurogrowth factor. Basically, your brain continues to
Repair itself.
repair itself.
So you don't get dementia.
Mm.
Right? So that's
Oh,
this
that's
whole,
where we're going to
yeah,
mention.
yeah.
Got it. We tied it back in.
Yes. See, there was a point to all of this.
Oh.
So you have to be able to, if you want to talk about feet and dementia and the connection, obviously it's there because it's movement and it's walking.
That'd be
right?
interesting studies to look at people with dementia and their physical activity level. That'd be interesting to see what's out there with that.
Yeah. Oh, and did you know that people who are going through Alzheimer's have sensory rooms? And they use touch and texture for them to connect.
No.
Yeah, and feel safe.
They
So
have-
there's sensory rooms in Alzheimer's rooms. Alzheimer's centers have sensory rooms.
Oh. Where they just go kind of like touch
light,
and feel?
texture, anything, just so they can kind of connect. And
Got
it
it.
keeps them calm.
Wow. I think that's, the people I see usually, my average person is somebody who's active and they have something. Plantar fascia, mostly mine. I love the back. That's my favorite. Disc, joint, facet.
Yeah.
I love it. Love the mechanics of the spine. And so I don't necessarily see these people with these pathologies like that. But I really do, hope that you're able to get this into, even into healthcare, into insurance would be great. I know it's a little slippery in there, but at least it gives this thing more, it gets the product in more people's hands.
Yes.
And
Yeah.
that's so important.
Yeah. My goal, like one of my dream achievements for Naboso would be, this sock doesn't have grip on the outside. It has leaves on it, but it doesn't have grips on the outside. But to be for anyone who has a stroke. And as soon as someone has a stroke, throw them in the socks so that you're stimulating the feet and the nervous system right
Might
away.
as well say concussion as well on
Well,
that.
oh yeah, concussion is a huge one also. Really any brain injury
Right.
should be get their
Especially
feet stimulated.
and the hands on something like
yeah.
that too.
Yep.
Wow.
Yeah, so you want to tap into there. So that would be one from like a medical perspective to get into that. We actually did start our FDA process for the insoles for neuropathy.
That's fantastic. That sounds like a low-hanging fruit and a fantastic entry point in there. How long is that process going to
Oh,
take?
it's expensive.
I was going to ask that second.
It's expensive. Yeah.
It is, huh?
Yeah, because
Because you got a legal team doing everything and filing a certain way and then approve
you
back.
have to do the research studies.
Oh.
Yep.
In a way, it sounds like it's like filing a patent, but you're now doing it from an aspect of that.
Yeah. So we just put that right there for now.
Okay. Well, you got somebody else doing it.
Yeah.
You got somebody, hire somebody. You do that. It's great. Your
Yes.
deadline's this day. You're fucking fired.
Yeah.
Well, this is fantastic. I don't know if there's
Thank
anything
you.
else we want to talk about. I want to sum it up though. Your background, podiatry. You actually went athletics, podiatry. You went into athletics, then you went back into podiatry, and doing the barefoot movement was the barefoot workout was kind of what brought you on the map. But the media, controlled by big
Yes.
pharma,
Yes.
probably felt a threat in there, and so they changed the headline
Yeah.
and just put in the high heel part of this thing in there to try to
Yes.
slander you a little bit.
Yeah.
But it actually got you some attention.
I mean, it was great.
Yeah.
I mean, also at that time, media was very different.
Right.
Right. To have a publicist, and so that was 2010. PR was very different in 2010 versus 2025 because now it's Instagram. Instagram was not a thing. What
Right.
it was in 2010, if people remember. I'm a little bit older than probably some of the
Facebook.
listeners.
But then
right?
again, that was
Yes.
most of my friends back then on
Yeah.
Facebook.
But it was, and then this is pre-COVID. I was in New York City, so I would literally go to the TV show and do the media isn't like that anymore. Like you could go on, the Today Show and tap in virtually. So it's very different now. It's not as fun.
It's different now.
Yeah.
It's easier now. Well, the other way is the old school way. But anyway, so you go media route, had an engineer, read some research on the stimulation, came up with a stimulation, came up with a stamp, to back that up too. You're still performing regenerative procedures today, and I'm so happy I learned about
Yep.
those. Fantastic. And I'm sure the combination of doing regenerative with the right movement, with the right stimulation of the feet with this, that is a sweet spot. That is, I'm 100% on board with that. That is like what a combination that is of doing it through different growth factors with light therapy. What do we call it? Photoreceptive therapy?
Photobiomodulation.
Red light therapy.
Little systemic enzyme in there too.
Is it red light therapy or infrared? Because red light therapy is pretty superficial.
So red light therapy has near infrared and the red light.
Oh, it does.
Yeah, red light and near infrared. Most boxes do.
Yeah,
They'll have
they're together,
both.
right?
Yes.
Yeah.
And then the near infrared wavelength penetrates deeper into the tissue. So it's actually really good for bone. It can get deep enough into bone. So I like that. Far infrared, that's like saunas, right? So different wavelengths.
Yep.
There's a blue light. So blue light is a little bit more superficial. I just learned that blue light is really good for fungus.
Oh, interesting.
So foot fungus.
Oh, wow.
Very superficial cases,
Yeah.
though.
And El Natural, too, which I like. That's great.
Natural. But yeah, so I think light therapy is, when you look at the research of light therapy, there's a lot of really strong research.
Oh,
So
I definitely see
like,
it. There's a book I read. It's called The Day After Roswell. And it was a guy who was in charge of the, he was down, he wrote, and of course a year later he died. He released him, he was 70 years old, he's military. And what he said was at the time he was, I think, a Marine or something down at Roswell, and he saw the craft that was recovered. And he even saw one of the dead beings. And then so whatever 30 years goes by, he's in the Pentagon, and he got put in charge of those Roswell files. And then what he said was, he goes, what we did is we had, it was a real simple playbook they did, was they would find these downed crafts. They would go, like back in 47, they go in this craft and they pull out something, and it is a laser. And he says what they do is they send it to somebody like MIT saying, we've acquired foreign technology.
okay.
You can patent it. We just need to know what it is and how we can use it for our military.
Sounds like a conspiracy.
Aren't most of them true, though?
I just like,
Isn't that true? Isn't it something?
what's about?
There was a senator, and he's like, I think conspiracy theorists are 37 wins and 0 losses. And so the point is he's making is that, like, I've dug deep into like extraterrestrials.
Oh,
And even there's multiple stories of people being, you could say the word abducted, but some people have had pain, and they've had light energy on them and healed. And so between that acquired and these stories about these things, and I'm into this stuff. I'm like, yeah, that there's advanced technology in
That we
this
do.
that we are now just, because think about us now, we're lasers. Yeah, we're like Neanderthals. We're shining it in eyes. Okay, don't shine in eyes. What does it do? Okay, it points over here. Like we get this new toy. We're like fucking shit up, and then we think it's good for everything. We go lasers,
Okay.
good for this.
Yeah,
But
yeah.
eventually we realize that it's got a couple.
Dial it in
that's
a little
we
bit.
Dial it
Dial
in.
it in a
We
little bit.
dial it in a little
Yeah,
bit.
yeah.
So that's why I believe in
Got it.
lasers.
Do you also believe in Bigfoot?
Well, into Yeti, yeah, of course.
Okay.
Yetis.
Yeah, it
Yeah.
is. Okay.
So Yetis are a humanoid creature, and this is what. And so I can get into this different, but this was a topic I spent. I mean, I go deep in things like thousands of hours. This.
Okay.
Not on.
I'm
just,
sorry to the listener.
Not on just Yetis. Now they're back in tune again with this thing. Okay. But so Yetis are said to be a humanoid creature.
Okay.
And so they are of humanoid, and they are programmed to be very scared of
Humans.
and so they stay a distance.
Yeah.
But they're connected deeply with the animal world,
Okay.
very deeply, even telepathic communication with each other.
Okay.
And so these things are a humanoid, and there's maybe thousands, maybe millions of these. And just recently, so I've got a guy, Hank. So Hank is a veterinarian.
Okay.
And a friend of mine. And he is a solo guy, he was married before, but he's a lone wolf guy. And he lives right now in Idaho, and he's got in the
Yetis.
middle of nowhere. But he was in Green Bay, outside of Green Bay, in the woods out there. And he tells me, and you meet this guy is a well-known vet. He works with horses. I mean, he's just got a really good name. And he's like, Mike, we had him living on our property. He goes, whenever it was cold in the winters, he goes, I would leave out food. And he was crazy as I'd even put cameras out, but every time I got the cameras would be turned and there'd be no footprints and that food was gone, but they would take the food. He goes, I would go outside, and he said he would have a stick, and his friends come, if he would hit a stick against a tree, no echoes, there would be a distant tick back. He'd go tick, 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 and there's a pause, tick, tick, and it would change different locations. He goes, I was fully confident that if I was out in the woods and anything ever happened to me, he goes, I was fully confident that they would put me back in my house.
Oh, wow.
Yep.
Okay.
He said he
So
felt
he had a
looked out
positive,
after.
energetic relationship with them.
He felt
Okay.
looked out after. He sent me. I have a photo on my phone. He has footprints of one of them. He startled it, and he took a photo of this thing.
Yeah.
It's a
So,
legitimate looking track.
well, the reason why I'm asking is that I was on the TV show Expedition Bigfoot,
Yeah.
which, as soon as you mentioned UFO, I was
yeah.
like,
Oh, that's right in the
oh, yeah,
category.
Bigfoot.
Yeah, sure.
Exactly.
Uh-huh.
But yeah, it was so fascinating going on, and they sent me footprints of Bigfoot,
Yeah.
or what they thought was Bigfoot with this humanoid, whatnot.
Yeah.
And they sent it to me, and then I would do an analysis on the foot
Yeah.
and make assumptions, and I would calculate the height.
I'm jealous.
So
It
I'd
sounds
use,
like so much fun.
I can send them to you if you want. They're like plaster casts of the
What?
Bigfoot impressions. And then from it, I did forensic podiatry. So I did these mathematical calculations from the footprint
So
and
jealous.
figured out how tall they would be.
Well, what did you discover?
So one of the footprints, I calculated that the humanoid or thing would be about 9.5 feet tall.
Yeah.
And then the other one, which was smaller, that they were thinking was like the kid or something younger,
Yep.
was like around 7 feet. And then, so it was the first episode I was on. I was kind of doing this. And then I was on another episode in this current season where I analyzed gait. So they had several. And I was like, based off of this, I am assuming that they are walking like this based off of footprint analysis. And it was so fascinating because I never get to geek out like that. But I was like, oh my gosh, this foot looks very humanish,
I'm
right? Like it's,
envious.
yeah.
This
I'll
sounds-
send you a link to it. It
I
was
would
so much
love
fun.
that.
It was so much fun.
You know
And
what
they-
I would love is I would love to do, if someone's out there that knows this, hire me. Let's say somebody's robbing somebody a bank or something, got a ski mask on.
Mm-hmm.
I would love to help them identify the biomechanics of the suspect.
Yeah. So
Because I had my cousin, he's got some friends that are, but his one friend supposedly put a mask on, like robbed a gas station, and there's footage of it, and it went all over the news. And as soon as I saw it, I'm like, yeah, that's Reed. That's him. That's for sure him. That posture, that left shoulder, scapula, that is 100% him.
Oh my God. So
Sorry, Reed. I think you're
love
past your
that.
statute.
Oh
Maybe
my
not. Who cares?
So I don't know if you knew this, fun fact. So before I got into fitness and all this, my bachelor's is forensics.
No.
Yes.
Forensics?
And
How
I
cool.
did my
Can you bring me in on this stuff?
internship.
Any more future forensic stuff?
Sure. So what
Please.
my internship when I was, I don't know, 19 years old, is I had to assist in all these autopsies.
Oh.
I know, I was 19. It was ridiculous. And then I had to do this presentation from the medical examiner. I was like all in. I was going to be a PhD forensic detective and yep. And then I was in New York City doing that forensic DNA research, and it was
How'd
so
you
cool.
get the forensic for Bigfoot?
How did I get invited to do that?
Yes.
And I think they just found me they just
Really?
contacted me, the Discovery Channel. And they're like, you seem to know about these things. So do you want to be on our show?
Wow. Can you send me those things? That's fun.
I will. It was so much fun.
Oh, my goodness.
And I was like, I think that they did it because I love to talk about mechanics.
Yeah.
And they didn't know about my forensic background.
Yeah.
And then when I told them, they were like, oh,
perfect. Even more perfect.
Yeah. So it was great.
Wow.
Yeah.
Yeah. Yetis. That's for next. Do tune in for the next episode. It's gonna be Yetis and UFOs. I think we should wrap it up. I think we got an event to go to, or something.
Oh, we do. I mean, it probably is over, but
We're at the Barefoot Shoe Expo in Denver. You know, my wife says, she goes, sounds like a bunch of nerds. Hey. But we're down to the Barefoot Shoe Expo, and so I'm speaking in a couple days. Tomorrow, Saturday. What are you speaking?
Friday, Saturday, both days.
You're doing both days too?
4.
Okay.
We have our booth.
Yep, I'll be at your booth.
Good.
I'll be at your booth.
Come say hi.
Yeah, I'll come.
Check out our flooring.
Oh, it's there?
We have 400 square feet of flooring.
Oh, great. I'm excited.
Yeah.
I definitely want to get some gym floor. You know what, it would work really well? For everyone out there, home gym. Big mirror. Think about your lifting station right there, where you fit a barbell right there. Nice station in front of a mirror. Probably an area for you guys 6 foot by 6 foot right there. And I'm sure it's strong enough you could drop a barbell. Well, you probably would. You would still want the barbell on maybe some wood if you can, right?
Sure.
You probably want.
Yeah.
But for the foot position, can't wait. This has been really fun. I've learned so much.
I know. I didn't have to fly to San Diego to do this.
Oh, right. Look at that. Came to you.
How convenient.
Well, it's so nice to officially meet you in person, too.
I know.
And I love what you're doing with
Thank
Naboso.
you.
I really wish you the best with this. I really do. You're onto something. It works. It's simple. It helps people feel something instantaneous, which is really nice. I'm envious with, because I'm always teaching people things, and then you put it on something, you go, oh, okay. I'm like, it's good. That's great.
I know. Yay, thanks.
But love it. I'm always going to be
Thank you.
promoting you. I'll be helping you out and promoting you guys in the workshops, too, because I love the product.
Thank
Love the
you.
product. Can't help but promote it.
Thank you. That's just one step for people to appreciate their feet. That's
One
honest.
step.
I'm no pun intended. I guess
no
a pun
pun. There's
intended.
something
Pun
in there with that.
intended.
Something
Pun
in there with
intended.
that.
Yes.
Yeah.
But yes, if any of the products make it a little bit easier for people to think about their feet, then my job is done.
Exactly. Yep.
Then I can sleep
And
at night.
it makes you find Move You too to help you. I'll help you get the movement right. You combine it with this and that. And if you got issues with like chronic plantar fasciitis, and if you tried everything, including Move You, our programs, knee, foot, ankle, go find Dr. Emily. We'll put links everywhere. I don't know. They're all over the place. Just look around with your eyes.
Just search her.
If you can't figure it out, you'll never figure out how to make an appointment with her. So, okay, this is your first hoop to jump through. All right, everybody. Thanks for tuning in on another episode of the Fix Your Shit Show. And until next time.
Thanks.